Good morning. This talk is about what we believe to be a necessary ground to targeted focal therapy, the cartography-based quality control of prostate cancer care. This work is presented by Pierre MOZER, Antoine, LEROY, HENRI, and Roland van VELTHOVEN. Targeted focal therapy is an emerging solution for localized prostate cancer in selected patients. Recent works pointed out the success and failure of that quality-of-life-oriented approach that can be resumed as follows. The success of targeted focal therapy requires first a fine patient selection and target definition. Then we need precise imaging and guiding to place on effective, predictable and localized therapeutic agents. We would add that we need data record and recall capability to multidisciplinary decision-making before and after the treatment. So how to meet these challenges? One proposed a multimodal 3D cartography platform allowing first to record on one device the fusion of biopsies localization and different images modalities such as multi-parametric MRI, PET or CUS, and this from cancer diagnosis to post-treatment follow-up. The purpose of this presentation is to evaluate the ability of Trinity, the 3D cartography platform of Coelis, to meet targeted focal treatment requirements with a retrospective study based on three aspects: precision, efficacy, and quality control. Let's start with the precision basis. What millimeter precision can we expect with the state-of-the-art cartography? Ukimura performed targeted biopsy on phantoms MRI lesions and evaluated the overall precision of the guidance by MRI fusion thanks to the injection of an MRI tracer. They obtained a precision of 2.92 mm on isoechoic lesions, matching the size of significant lesions. Let's see the results for in vivo studies. Moldovan placed 3 fiducial PET patients on 15 patients and evaluated the placement precision with MRI fusion. They obtained an XY median precision between 2.5 and 3.6 mm, set reasonable for clinical practice, matching the size of significant lesions. Malevo compared the precision between cognitive and fusion biopsy on 88 patients, measuring the distance between the core and target center in the 3D cartography. A considerably higher precision is measured with fusion biopsy, 2.8 mm versus 7.1 mm with cognitive biopsy, matching again the size of significant lesions. A considerably higher cancer detection is also measured in patients with prostate cancer. From an efficacy point of view, some studies evaluated the diagnosis efficacy of multiparametric MRI associated with appropriate scores, combined with targeted biopsy. Let's focus on the relation between true and false positive rates. On such curve, Portales obtained an area under the curve of 0.86 with 129 rebiopsy patients. Renard-Penat obtained an area under the curve of 0.90 on 118 primary biopsy patients. A reasonable efficacy is thus perceived even for repeating biopsy session, a key point for post-treatment surveillance. In addition, several studies, for instance, MOZER on 152 patients and Peltier on 129 patients, showed an ascending correlation between Pirate's score, Gleason score, and cancer core length. Such studies underline the cancer qualification efficacy of fusion-targeted mapping. This approach is also supported by a prospective randomized study with 175 patients performed by BACO. They concluded that the traditional 12-core random biopsy may be replaced by 2-core MRI truss targeted biopsy for detection of clinically significant prostate cancer. Finally, let's talk about the quality control provided by cartography. One of the first studies of cartography-guided biopsy was presented by MOZER in 2009 on 32 patients, with 12 prostate core per patient. The aim of the work was to verify that biopsy were conducted within the planned targets. The success rate was 100% for targets in middle and right parasagittal part and 53% for targets in the left lateral base. Moreover, a significant improvement of the operator's dexterity over time was observed. Such technology clearly improved the distribution of prostate biopsies. It provided a detailed map of each patient showing biopsy zones with a significant change in routine clinical practices. Yukimura evaluated the quality control provided by cartography in the context of rebiopsy on 25 patients. First, look biopsy biopsies were used as targets for the second look session. An accuracy of 86% per lesion is measured. The real-time 3D truss-documented biopsy mapping technology allows a precise revisiting targeted biopsy of previously documented low-volume cancer foci. In conclusion, multimodal prostate cartography proves effective and necessary to fulfill preoperative and postoperative requirements of targeted focal treatments. It can be used for disease monitoring, treatment planning, and follow-up. Cartography defines the target lesion ROI plus safety and free of cancer zones from multiparametric imaging inputs fused on a software imaging platform. Such personalized data management leads to precision, safety, and quality control. As a perspective, further enhancement will be provided by the association of 3D cartography with co-manipulated robotic assistants. Thank you for your attention.